Centor back last September, I guess, at on the VA wards.
And, it was my first rotation back after being banished to my house.
COVID land. That's right. For the house and the golf course. Yeah.
Yeah.
Anyway, so he got to come back to this case. So that was fun. Anyways.
And what are you doing next year?
Next year, hospitalist. And then still considering cardiology fellowship after that.
Sounds great. Okay. Priyanka, tell us about yourself.
Hi, everyone. Can you hear me?
Absolutely. Loud and clear.
Awesome. I'm Priyanka. I'm so excited to be here. I'm a fourth-year medical student at UCSF and have heard amazing things about unRemarkable labs and have been involved with CP solvers. And I am applying to internal medicine for residency and starting this summer, which is crazy.
Yeah, and you really, you can't imagine how crazy it is. It really is crazy. And it is the most educational year of your life. And you don't even realize it until the year's over. And then at the end of the year, when you see the new interns come in and says, was I like that? And you were. It's amazing how much you grow during that year. It's hard work, but you get paid back real well. Jamal, tell everybody about yourself.
My name is Jamal Benson. I'm a hospitalist PA based in Pennsylvania. Actually, I was involved a little bit with CPS before I actually started working. I just think this whole series is wonderful. I still watch the series when I'm at work, when I'm finished with my notes. And I actually caught an SGL2 induced DKA, euglycemic, because of this series. So I can't just, my praise for it is just off the roof.
I can't tell you how happy that makes us, right, Sean? So, I mean, the biggest thing is we want to help everybody become better at paying attention and thinking. If we get you to think, that's great. Okay. This case is a little different in a lot of different ways, and I'm just going to let Scott just start talking about it, and then we'll figure out exactly how to approach each part.
Yeah, sure. So chief complaint, I know you like to start with that, so we'll start with chief complaint. We'll say left-sided back pain.
Yeah, you can go ahead and give the HPI.
So kind of more about the patient. I'll give you the intro here. So he's a 56-year-old African-American man with history of kidney stones and Crohn's disease, who presents with a one-day history of left back pain, he says, and hematuria.
Okay, Jamal. So the ER calls you up and says, we're going to admit him. What more information do you want?
So I think we already have a lot of information just with this initial aliquot here. Biggest thing that I'm noticing is with that Crohn's disease, we have to ask ourselves the question, is this person on steroids? And if so, are they immunosuppressed? Because that's going to widen the differential, just like HIV would widen the differential. So in thinking about this, I'm trying to rule out other red flags as well. So questions I would want to ask this patient, whether or not they have any like anesthesia, so any sensation loss within their groin region, if they've noticed any incontinence, is that bowel or bladder? Because things like cauda equina definitely come up in my mind. And I'd want to rule out the red flags before I go any step further.
So, and we had a really good question in the chat. Is this some kind of a side effect of the Crohn's disease? So it would help. So we're gonna sort of respond to your questions by giving you the information you want. Why don't you tell them what medications he was taking?
Sure. So he's been on mesalamine for his Crohn's disease since he was diagnosed in 1982. Is not currently on any steroids, but he has been in the past. It's a little unclear as to why he stopped them at different times. But he thinks that he has a history of nephrolithiasis, and he thinks that's been better when he's been on steroids. But currently, that's the only medication that he's on other than aspirin and atorvastatin. That's it.
Okay, so Priyanka.
As far as, Sure, go ahead.
Okay, Priyanka, let's go ahead and get back to now we have this extra information. What other questions do you want to ask the patient?
Yeah, so this is very interesting because I think that his nephrolithiasis and Crohn's disease like potentially localize his back pain, although I don't want to anchor on those past medical histories. So knowing that he's on mesalamine, aspirin, and atorvastatin, so the aspirin and atorvastatin, I'd want to know like when he started those, why he started those, what is his cardiovascular risk? Because in a middle-aged African-American gentleman, if he does have a history of hypertension, is it controlled, is it uncontrolled, or hyperlipidemia? I'm thinking about other must-not-miss diagnoses like aortic dissection in a patient like this. Additionally, with the mesalamine for Crohn's disease, I'm curious what dose he's on and has been on any other medications. I think that mesalamine, maybe he hasn't been on a biologic before, but I want to understand how well controlled his Crohn's disease is, because that would clue me into whether this could be a manifestation of Crohn's additionally. Let's see, he's not currently on steroids. And then the hematuria, curious about that because with Crohn's disease, well, I want to get more information about the hematuria. Like what did that look like for him? Was it frank blood? Was it like blood in his urine that was pinkish, or was it blood in his stool that he thought was actually from his urine? So I just want to get more information to clarify and better localize like where his symptoms map to.
Okay, Scott, reveal a lot more.
Okay, sounds good. So I actually don't have the dose of mesalamine. It was a standard dose. He wasn't on any kind of high dose of that. He had never been on any biologic medications for Crohn's disease, I think because he acted like it had been fairly well controlled, intermittent flares that he had used prednisone for in the past, but otherwise pretty well controlled. As far as his hematuria goes, he's just been frank blood, similar to prior episodes with nephrolithiasis for him. And he has not noted any melanodermatitis. He's pretty certain it's coming from the urethra. And then what was some other questions I may have missed? Anything else I missed?
I think.
His ASA. Sorry, his ASA and atorvastatin had been on because he had had a cryptogenic stroke back in October of 2019. So he had been taking it for close to a year at the time we saw him for cryptogenic.
So here's your question, Jamal. He's had kidney stones before. What questions do you want to ask of the chart? And we're fortunate that we really have good medical records on him.
Questions in terms of the chart.
Yeah. So we know he's had kidney stones before.
Mm-hmm. So I guess, has his kidney stones resolved on their own, or has he required interventions with nephrostomy tubes and whatnot, or just shockwave? Because that would tell us a lot. The Crohn's, I think, in and of itself can predispose to having kidney stones, but at the end of the day, I think doing a deep chart dive, seeing whether or not he has had resolution with these kidney stones in the past would be helpful. The other thing that we can consider too, I know he's 56, but if he has a history of hypertension, he talked about family history with this guy, and you see that it's also something that's happening in the family as well. Polycystic kidney disease is not something out of the question. This is a pretty common presentation with a hematuria, hypertension, and a family history. So that's something I'm considering, but yeah, chart review would be nice.
So this is called unRemarkable labs. So I'm thinking about a lab test. And here, we were fortunate enough to have this. Have they ever analyzed a stone? Because there are different types of kidney stones. that make sense?
Yes.
So if you have somebody who comes in with kidney stones, it's probably worthwhile to know what kind it is. So did we have that information, Scott?
I don't think so.
Yeah, we did.
I don't remember having that information.
Yeah, we
Did we?
did.
What was it? Or the
Yeah,
calcium?
he had calcium oxalate stones.
Oh, calcium oxalate stones. Okay, I thought we just assumed that. Okay, so we knew that. I didn't know. I didn't
We
remember
actually
that.
had a stone analysis. You know,
Okay, so calcium.
we're trying to remember, you know, at my age, trying to remember from 4 months ago, could be, I could be just making it up. Okay, so.
Well, either way, I think, yeah, it is this time. So calcium oxalate in the past, yes.
Right. And so how did the ER actually document that he had stones this time?
So they did a CT scan before we saw him. Is that what you're talking about?
Yeah.
Okay, so they got a CT scan in the ED. He actually had left-sided flank pain, but he had renal on the right side. He had, I think, let's see, a 5 millimeter non-obstructing right renal calculus and a non-obstructing 8 millimeter calculus in the right renal pelvis. Nothing on the left.
Yeah, and he, when we talked to him the next morning, he said he thought he'd passed the stone.
Right.
But then we found
His pain had gone away by the next.
So now we have a guy who has multiple stones. So Priyanka, on a previous admission, he'd had these stones, and they said, okay, that's a side effect of his Crohn's disease. Does that make sense?
Yes, I recall that association. And I need to remind myself the pathophys of that. I think, actually, no, I don't remember the pathophys of that.
Does it have anything to do with like the fat malabsorption with the ileum, or no? Maybe that's another disease process.
Yeah, you're right. And they had thought he
Okay.
had ileal Crohn's.
Oh.
So the idea was that he had been having fat malabsorption leading to increased binding of intraintestinal calcium. And so free oxalate being transmitted through to his colon and being absorbed.
So that was the assumption.
Mechanism in Crohn's, calcium oxalate. That was the assumption. Yes, that's the assumption.
And now we get to the.
And our assumption on.
Yeah. Go ahead, Scott.
Okay, sure. So do you want labs next then?
Yeah.
Like what we did the next day or whatever it came back?
Yeah, you know, we had to get labs. And you knew labs were going to become important here in just a second.
Yeah. So this seemed like a pretty straightforward case, and he actually, we think, passed the stone, and he felt better the next day. And so anyways, these labs came back the next morning and kind of made us a little more interested. So I'll just start with the basic labs. So his BMP, Sean, was sodium of 134, potassium of 4.5, chloride 98, bicarb 26, BUN of 35, and creatinine of 3.6. And from a baseline creatinine, that was around the same. So that was about his base. We also got, albumin that was 4.6 and a calcium that was 13. And then I wrote down his alkaline phosphatase was normal 85, and that was kind of all the labs we had back at that point. And then his CBC was unremarkable, and his UA had 3+ blood, greater than 182 RBCs, but otherwise was pretty unremarkable.
Okay, so Priyanka.
Okay. So looking at the labs, just looking at the BMP first, nothing really stands out, especially since the creatinine seems to be stable from his baseline or at his baseline. He definitely has an elevated calcium. So I wonder if he is taking any medications that we don't know about that are increasing his calcium. I wonder if this is related to the malabsorption piece, and as such, he's having like the calcium oxalate stones. I think vitamin C overdose can lead to calcium hypercalcemia. So I would ask about that. And I think in this patient, I think, yeah, that's what comes to mind right now, is trying to, like, if I were to, instead of being very broad on my differential for hypercalcemia, which is honestly very limited, like mapping it onto this patient, I would really think about if he's on any other medication. And then for the imaging studies, so, sorry, 1 second. There's, on the right, there's a renal calculus, and then it's shown in the right pelvis, which is really interesting that he's having left-sided pain. I'm not sure what to make of that. I have to think about that.
His pain is actually.
I will say his pain resolved.
Oh, okay, okay. So this is like in the future after what he thought he passed a stone.
Right.
Okay.
Yeah, he felt that he'd passed the stone, and he was really admitted because he was in severe pain. And by the time I saw him the next morning, he felt pretty comfortable, but he had red on his calcium, so we had to get excited.
Yeah.
So
that's what I have for you.
So it's probably worthwhile, Jamal, to think through, what do you do in this situation? So we were blaming the stone on his Crohn's disease. So do you want to know more about his Crohn's disease?
I would love to know more about his Crohn's disease, but do we have a total protein on this guy?
Protein was 8.2.
8.2, okay.
Okay, so I like that thought, because you're thinking about what are all the possible causes of hypercalcemia. And we'll get back to that in a second. A previous team had just assumed that this was Crohn's. We looked back to see what its calcium was on that previous admission, which I think was about a month or two before. Is that right, Scott?
Yeah, I did with that year, and it was elevated as well. I didn't write that down.
Yeah, it was mildly elevated then, but it was clearly elevated before.
As far as medications go, so he takes no over-the-counter vitamins, no vitamin C, no vitamin D. He also takes no Tums or anything with calcium.
Okay, so we wanted to figure out what was going on with the Crohn's. We thought it was really weird that he was on mesalamine. He was on no biologics, and he said he always felt better when he was on steroids. So Scott, what do we do about the trying to understand his inflammatory bowel disease?
I think we tried to see if he ever actually had a biopsy to confirm that he had Crohn's, because we thought it was interesting they were using mesalamine, which is typically used for UC and not Crohn's, and they hadn't been on anything, and why they had stopped his prednisone. And I can't honestly remember the reason why they stopped his prednisone or why they never tried biologics. But from what I remember, he didn't have a previous biopsy because he was diagnosed in 1982, and far back as CPRS goes, it doesn't go that far back. So he wasn't really actively being followed, at least not with.
If I remember right,
Crohn's.
he had either one or two colonoscopies with some biopsies that were all negative and did not show any inflammation of the distal ileum, and his CT scan did not show any evidence of inflammatory disease of the small bowel.
So he did have prior CT scans. I don't know at what point you want me to tell any of this. So I'll wait on you. If you want me
go
to
ahead and give them
because
that.
our next step in this was okay. So he had prior CT abdominal scans that showed some mesenteric adenopathy, but like Dr. Centor said, no ileitis or evidence of that or any other inflammation in his bowel, and that was essentially it. But he did have some mesenteric adenopathy, what they called that.
Yeah, and we went down to radiology and looked at it. So now we have that. How do you want to evaluate them? So let's go through, make sure we know how to think about his hypercalcemia, because now instead of this being clear Crohn's disease causing the kidney stones, he still might have Crohn's disease, although we can't prove that he has Crohn's disease. We're sort of a little skeptical, and we talked to GI and they were skeptical also, but we know he has hypercalcemia. So let's think of the groupings of things that will lead to what tests we order for hypercalcemia. Jamal, have you worked up any hypercalcemia and have an idea of what tests you might get?
Yeah, it's very interesting, but my first test would actually just be a question to the patient: are you taking antacids or not? Because I've seen a couple of those slip by, and including on my own self, and then someone catches it. So, I think it's third most common cause of hypercalcemia. So it's a very important question just to ask because you hate to miss it. In terms of testing, the reason why I asked for total protein was just to open my eyes towards whether or not we could be dealing with a multiple myeloma-like syndrome. If I had seen an elevated protein gap, if he had a degree of renal insufficiency, then I would have been more in that camp. We got to ask other questions too. I mean, this patient is not on lithium, but that's another consideration. Hydrochlorothiazide can do it too. And then we want to talk about hormonal causes and then lytic, like Brown processes, vitamin D mediated processes, like a sarcoid or lymphoma. Testing for that, I'm not very familiar, but I will say that I know a chloride to phosphate ratio can kind of put you away. It's either away or towards a primary hyperparathyroidism. I can't remember which one it is, but getting the chloride to phosphate ratio might be very important in this patient. We can also consider adrenal insufficiency, so cortisol could help there too. TSH would be nice as well, and then go from there.
Great. So what I'm gonna do is I'm gonna restate this in a slightly different order the way I think about it, and see if that's helpful. Number one, you want to see whether or not it's hyperparathyroidism, because that's one of the most common causes of hypercalcemia. So we'll check a PTH. We have no evidence to support cancer, but we're still going to get PTH-RP because that can be hard to diagnose. Because of the adenopathy, we're going to go ahead and get vitamin D. And as some of you have heard me say before, you have to get a 125. And sometimes you order both a 25 and a 125, but 125 is the culprit in the granulomatous diseases. And that includes all the granulomatous diseases, including, as some people have already mentioned in the chat, lymphomas. A TSH is a really good idea. I've definitely seen hyperthyroidism do this. We didn't really have anything to go on to think about Addison's. He did not have the body habitus of acromegaly. And even though he doesn't have a protein gap, if he'd had anemia, we might have gotten an SPEP. I don't remember if we did get an SPEP, but you can make an argument for looking for multiple myeloma, and we have diagnosed it with a normal protein gap. So it's probably worthwhile to think about that. So that was our thought process, and we were quite interested in this mesenteric adenopathy. and wondered whether his GI, he didn't really have a lot of GI complaints at this point in time, and whether or not whatever complaints he did have, he wasn't having a lot of diarrhea or anything. But this mesenteric adenopathy really struck us a great deal. Does that make sense to everybody? And I'm more than happy to answer any questions. There's one question that has often come up is, can Crohn's disease in and of itself cause hypercalcemia? And I've tried to look that up and find conflicting data. I don't think it really does. So Scott, why don't you go ahead and let them know how we approach this and see if that
Sure.
helps at all.
Yeah, so we kind of went down the, is this PTH driven or not PTH driven? So we checked the PTH. The PTH was actually low, 2.57, which is lower than normal is 15. So then we started thinking, well, if it's not PTH driven, kind of going down that algorithm. So the PTH related peptide we obtained, which was in the normal range. It was not high, 17. And additionally, we checked, we checked the vitamin D level, a 25 vitamin D level that came back first, and that was actually low, which then led us, which we'd already sent off a 125, but at that point in time, because of the fact that that was low, going down kind of our thought process, led us to think about, well, has he had any former imaging that we hadn't looked at? So we looked at a chest x-ray at that time and found an old chest x-ray that looked like, and I don't think it had been read this way, but we got our radiologist to read it again as some hilar lymphadenopathy. And so with that, the 125 came back elevated. This 125 vitamin D came back elevated. We also checked his SPEP, UPEP, which were normal. Make sure the mild diagnosis is out there. And then I think, Jamal, you mentioned tons of other causes, which were great. So his TSH was normal. We did not do like a quart stem on him. Another cause of hypercalcemia is vitamin A, high vitamin A. So we checked the vitamin A and his was normal as well. And then I believe that was kind of it as far as what other things we looked at. So, and then we got interested in the lymphadenopathy in his abdomen because we were thinking maybe once we found his x-ray and thought through the process that this could be sarcoidosis, and he had never been diagnosed with that, we then started to kind of reconsider what his Crohn's diagnosis may have been, especially in the setting of prior biopsies that were negative, essentially. But he still had this lymphadenopathy. So our thought process at that point in time, we talked to GI about trying to get him in to get biopsies of his abdominal lymphadenopathy to see if this could also be related to sarcoidosis, non-caseating granulomas in his GI tract, which is actually pretty rare, but the overlap between Crohn's and sarcoid is actually pretty common as far as the non-caseating granulomas, some of the processes behind the lymphocytes and how that's driven to produce them, and then also apparently genetically as well is pretty close. But the incidence of having both is actually very rare. So trying to explain all of this in one diagnosis, seeing his pulmonary findings was so. And that also helped us. So we also thought about other extrapulmonary manifestations, his renal disease as well. He had never had hypertension that was uncontrolled. He had never had diabetes. We were really confused about his CKD. So we got our nephrologist involved there and concerned for renal sarcoid. And they actually put him on, started him on steroids, and I rechecked creatinine later. His creatinine was improved, I think, after starting steroids. But then looking back and thinking, well, why did his stones even get better in the setting of prednisone? We thought likely to do with better control of sarcoidosis as well, less production of the 125 vitamin D, so less hypercalcemia.
Okay, so this is where we were, and we're still waiting for this biopsy to occur. He missed his first biopsy appointment. He has another biopsy appointment, but renal has seen in the meantime. We've made the assumption that he probably has granulomatous disease. We think it's probably sarcoid. The markedly elevated vitamin D, and I think they got an ACE level on him also. Did we get an ACE level, Scott?
I believe so. Yeah, it was elevated.
Yeah, he had an elevated ACE level. Now that's not a great test, but it supports our hypothesis, so we like it. That's called confirmation bias, by the way. When you see someone who has calcium oxalate stones and you're trying to control them, what other lab tests should you get? And I didn't think of this. Renal thought of this. Anyone in the chat?
Phosphate?
Uric acid.
Is it a phosphate? Oh, good. Oh,
Uric acid, because many calcium oxalate stones have a nidus of urate. And I didn't think of that because I don't see a lot of people with kidney stones, and I was getting so excited about the adenopathy that I didn't carefully think through everything. And he in December had a uric acid, and this is what I told you I was going to pull out on you, Scott. His uric acid.
Yeah, I saw that
His
lab.
uric acid was like 9.3.
Okay.
And so that's one way to help decrease the risk of further kidney stones. So when you're thinking about management, so we rarely get uric acid these days. It's interesting. When I was a resident, it was part of what was called the Chem 13. And the Chem 13 had LDH, it had uric acid, it had a whole bunch of things that we don't routinely check anymore. So we always knew what the uric acid was. But I think this is a clue on one way to help decrease his risk of further kidney stones while we're trying to work out and treat his hypercalcemia. Renal has in the back of their minds potentially doing a biopsy at some time. Kushal, why don't you tell people what you just put in the chat? Unmute yourself, Kushal.
Hi, everyone. Yeah, so I was just discussing a point that board exam usually ask a lot about, especially with, I think, lower urine pH and lower urine citrate level. The answer is to give potassium citrate to reduce the level of kidney stones.
Right. So I think there are two strategies here. One is to try to get his calcium under control. And in his December appointment, even with steroids, he still is running a calcium in the 11s. And now that they know he has urate, that's one of the three major indications for uric acid lowering medications. And we always start with allopurinol. And so I thought it'd be worthwhile to just spend a minute because we rarely talk about this. And so this is a magic question that we're going to let Priyanka is going to be an intern next year. There are three major indications in patients who either have gout who have gout, whether they have gouty arthritis or not. There are three indications for starting urate lowering medications, and here specifically we're talking about starting with allopurinol. And I'm throwing this in to make Sean very excited because Sean's going to be a rheumatology fellow next year. So has anybody taught you that, Priyanka?
indications for when to use urate lowering drugs.
Yeah. So in which patients do you start allopurinol?
So I've honestly never like started allopurinol or been in that process. I've always like seen patients that are already on that medication. So this is a learning opportunity for me.
Yeah, and that's why the reason I asked it is because this rarely comes up during your third year rotation. It will come up sooner or later when you're an intern, probably in clinic. But it's really an important question.
Yeah, I mean, I always thought that you would have to have like some sort of like gout attack to start allopurinol.
That's one reason. So recurrent gout attacks is one reason to start allopurinol. That's reason number one. This patient has reason number two. Uric acid stone.
Like
a
uric acid stone.
Yeah, uric acid in your stones. So nephrolithiasis is another reason. And the last one someone did mention now this is just gout patients. A bunch of people are talking about tumor lysis and talking about Rasbira case. We don't use that routinely in gout. We're just talking about gout, not in either spontaneous tumor lysis or treating a patient who has tumor lysis because the oncologist made that happen. And somebody did put it in the chat. Yeah, Sherry put it in. Sherry, why don't you teach them?
So my understanding is that with patients with tophi, they have like a precipitation of a lot of uric acid, and you want to like slowly trying to remove those because there's a niter that can easily cause flare.
You're 100% right. I'm so glad you put that in there. So tophi, tophaceous gout is an absolute indication for allopurinol. Now, let me just clue you in on the controversy. I actually did 2 podcasts on this. The American College of Physicians came out and said if someone has recurrent gout, that you just give them a dose of allopurinol and you don't remeasure the uric acid. The rheumatology organizations about had a gouty attack when that came out. They went crazy, and one of our favorite rheumatologists who we've had on here once already, and we'll probably have back Angelo Gaffo, just went nuts about this. It turns out that uric acid is soluble and crystallizes above a level of 6. And what happened was the American College of Physicians could find no study that showed that lowering the uric acid below 6 decreased the rate of gout flares. It's indirect evidence. They did not say that you don't go below 6 for nephrolithiasis and tophi. So everybody agrees with that. And there are two problems here about using allopurinol. The first is not enough patients are put on allopurinol for elevated uric acid that have gout. So someone with recurrent gout, anyone with tophi, and anybody with nephrolithiasis. And Sean, you're saying CKD3 is a reason?
Yeah, yep.
Okay, and I think that'd be a good reason in this guy. And then the dose of allopurinol, if you talk to the gout experts, is enough allopurinol to get your uric acid less than 6. So you do have to titrate this. There are data that suggest that it does make a difference. It's not complete data, but if you talk to almost any rheumatologist, and have you had these conversations, Sean?
This is always an interesting debate. I can understand both sides.
Yeah. So certainly with nephrolithiasis and tophi, you want to get it below 6. Most of the rheumatologists want to get it below 6. But the bottom line is the dose of allopurinol is not a fixed dose. It's a titrated dose to make sure that you've lowered the uric acid enough. Another good question, Sean, why don't you talk about when you start the allopurinol?
Yeah, so it came up in the chat, can you start it during a flare or not? And the traditional kind of teaching was that no, you don't start urate lowering therapy with allopurinol during a flare because you can potentially worsen or prolong the flare that they're having if you start it. And so they would usually just say like follow up in clinic, start it in like a month or something like that. But there's some newer data that you can actually start it during a flare if they meet indications for urate lowering therapy, and that it won't like prolong their flare. So something that's still a little bit controversial, and you can see good people do it either way. But if you do start that allopurinol, you do need to give them prophylaxis for about 3 to 6 months while you're starting that allopurinol up. Prophylaxis being NSAIDs, colchicine, or prednisone.
Okay. And that's always a very interesting decision as to which one you're going to use. It's easy in this patient because he needs to be on prednisone anyway because of hypercalcemia. But a lot of times we use colchicine. Traditionally, I've used colchicine for that. So I wanted to throw that in because I thought that was a very interesting twist in this case. We don't have 100% final diagnosis, but we're pretty certain that this guy does have sarcoidosis and probably has had sarcoidosis the entire time and may never have had inflammatory bowel disease. We can't find any good documentation of him ever having inflammatory bowel disease or having any colonoscopy findings that would suggest it, or any CT findings that suggest that. Scott, did I talk too much? I usually do.
No more than usual.
Yeah.
No, you're great. No, that's great. Yeah, I think I called the patient. And he said he was going to come in and get his biopsy, but I think until we get the biopsy, it's kind of hard for us to know what's going on there. But I did think it was interesting. It would be very rare, one to have both Crohn's and sarcoid, but also very rare to have intestinal manifestations of your sarcoid. So he'd be an interesting case if he ends up having intestinal sarcoid.
Yeah. So my summary is this was a very straightforward case that became not straightforward at all once we saw the calcium level, and paying attention to the calcium level, which and I don't want to throw anybody under the bus, and since you don't know who else had taken care of this patient, I'm not throwing them under the bus, but there was an elevated calcium that was not really paid attention to previously in a patient with kidney stone. And I think you have to do that. So Jamal and Priyanka, you get to think of the two most important things for yourself that we discussed today that you want to read more about it. And if anybody is willing to write some things in the chat of things that they thought were particularly useful about the discussion of this case, we really would appreciate anything that you put in the chat concerning this. So Jamal, we're going to let you go first.
So this was quite an interesting case for me. Something that I won't necessarily research on, but I'm taking away from the case is the background work that you both did, or your whole team did, particularly with looking at a chest x-ray from before and noticing that hilar adenopathy. You are getting the background and using it to inform the foreground, because a lot of times when people are coming in, you just look exactly at what's happening, but you're not necessarily trusting, but you're trusting your colleagues, but you're verifying. And I think that's critical for me as a practitioner. So that's something that I'm going to learn. I want to go over sarcord and the gap, the connection between what we just went over to. I didn't know that they were connected in any way, so I want to go over that. And I remember on a previous one of these lessons here, you talked about like ketoconazole as a potential treatment for vitamin D induced hypercalcemia. So I want to actually look into that a little bit more as well.
Yeah, that's we actually used that in another patient, and I love that you brought that up, because that's actually something I have in the back of my mind that might be useful again. Priyanka.
This was an awesome case. I'm really glad that I jumped in and learned a lot. I think what stands out to me is something that I think I did during this case, which was in some ways like anchor or trust the past medical history and try to make sense of the patient's presentation and symptoms, you know, layering on the past medical history. And I really appreciated the opportunity to step back and kind of question, like, well, does this patient have Crohn's? Like, can we really take that as a truth? And how does that change how we approach, you know, hypercalcemia? And also considering that this patient is on mesalamine and previously has had improved symptoms with steroids, that is really helpful to, like, as a learner and as a trainee, to like constantly do a gut check and say, like, something's not really smelling right here. Like, let me go after it and try to interrogate this a bit more. So I think that was awesome. And then the second thing that I want to look up and solidify for myself is indications for using the urate lowering therapies, and add that to my notes, because it's honestly, you're totally right, Uncle Bob, that hasn't come up as much, and it's something new for me. So thank you.
That was really, really good summary. One of the things that when I give talks about clinical reasoning, one of the things I say is to be skeptical of everything that anybody else has told you about the case, including yourself. So I never believed the emergency department. Not that I don't trust the emergency department. I just can't afford to believe them. I don't believe the referring physician. I don't believe the previous physician. And on day two, I don't trust what I said on day one. If something is bothering me, this is the for those of you who are old enough to have ever seen Columbo with Peter Falk, one of my favorite mystery shows of all time. In every case, there'd be some little thing that would bother him, and the calcium bothered me. And you can imagine, and Scott could tell you how excited I got that this guy had hypercalcemia, and maybe we have to think about everything fresh in this guy, because things weren't adding up. And so we took what seemed like a really routine, no-brainer admission, and had a lot of intellectual energy placed into us, which we think is actually going to help the patient. So I think that was great. Travis had a nice comment in here. And it was also about anchoring, about how as soon as we said Crohn's, everybody got excited about the Crohn's, and that's what everybody was thinking, but it was this other thing that just didn't make sense. And then we looked at the CT scan, and we actually talked to the radiologist about the CT scan, and if I remember right, Scott, he just didn't think there was anything there that looked like Crohn's.
Yeah, no, he said no stranding, no like evidence of prior strictures or fistulas or anything that looked like an evidence of Crohn's in the past. And it's for somebody who had had it for apparently almost 40 years, you'd see something at that time period, during that time period.
And I was going to say, I was going to come down hard on the imaging, because a lot of times in the ER, we like to, to teach, all of the radiation that then people with Crohn's and CT scans. I mean, some of these people have like 10 CT scans in a year. And I mean, that's tons of millisieverts of radiation. And a lot of times we, if they've had stones, we'll just do a POCUS on them or an ultrasound. And if they don't have hydro and they have blood in their urine. We're like, all right, it's probably a stone. You don't have a complete obstruction, and you try to pain control them. I mean, this is obviously, this guy has renal insufficiency, so you would probably want to get a CT scan on him. But that was, one of the things I was thinking during the case, just about, imaging people that have chronic diseases, and just to make sure that you're imaging with caution.
That is such a great point, Travis, and that we can't say that enough. We inherited the CT scan. One of the things that I know Robbie talks about a lot and Reza talks about a lot on clinical problem solvers, and I know we talk about it in many of our conferences at UAB, is if you're having a difficult time with the radiology report or looking at the film yourself, go talk to the radiologist. And it's amazing how often you get insights and they get insights from that conversation. I cannot say enough times that that one of my most valuable colleagues is a radiologist. And brainstorming with the radiologist makes you think through the case really well. And I think it helped us a lot here in thinking about this and understanding how to talk to GI about the case. Sean, do you have any good take-home points?
Man, I don't know if I can summarize it. I think everybody said a lot of good things so far. What I'm going to be looking at is when to check urate levels other than gout. So nephrolithiasis, it wasn't one that I usually think about, but it would have been helpful. Tumor lysis. And then really want to echo about imaging, just look at the past, because I think chest x-rays are the most commonly read study, and that makes them the most likely to have something missed too, because you just read them so fast that, oh, you missed that hilar lymphadenopathy. So.
Right. And that's why we are planning a couple of sessions with the radiologist. Those sessions will be 1 hour earlier because of his family's dinner time. But we will, we're collecting some chest x-rays and then some chest CTs, and then eventually some abdominal CTs to go over with them to learn some of the points. So yeah, we will have some that are an hour earlier. And Dr. May, our hematologist, is back from maternity leave. 7 o'clock is feeding time. So when we bring her back, and we have a couple of cases already collected for her, and we'll do some of those at 6 o'clock because this is a family-friendly Zoom conference.